G'day, I'm Dr. John Darcy, and welcome to the Jean Hales Foundation for Women's Health 2010 webcast, Making Your 40s Fabulous, Your Hormones, Your Libido, Your Health. Now, for those of you who don't know about the Jean Hales Foundation, it's a not-for-profit organisation that's dedicated to improving the health and well-being of women through research, education and clinical care. The Foundation for Women's Health accepts funding from government and non-government sources. Now, the important thing is it always maintains complete academic freedom, and that's so important. Now, this has all happened because the Foundation has been talking to women about their health in general. Women in their 40s. They're asking the same question time and time again, and it's through this webcast that we hope to answer the most often asked question from women in their 40s. It's also a time when women are thinking about their past and their future. Maybe the family's completed, their career has started and is on the way, and they're looking towards the future to work out what the second half of their life is going to be like. And so tonight is also about preventative strategies, trying to make the rest of your life absolutely simple. And we sincerely hope that wherever you're watching this on the internet throughout Australia, that you get the answers to the questions that are on your mind. Let me introduce my guests for today. Dr. Rosie King. Dr. Rosie is a sexual health physician, and she's written a couple of books, one of them called Good Loving, Great Sex, and the recently released Where Did My Libido Go? And also Dr. Elizabeth Farrell. Elizabeth is a gynaecologist associated with the Jean Hales Foundation. She's very well known, not only in Victoria, but right around Australia. So, welcome ladies.
Thank you, John.
Thanks.
Now, Liz, can I ask you the first question? What are the big health issues for women in their 40s?
Well, I suppose just their normal cycle, so our normal reproductive cycle, normal life stresses of relationships and all those things that Rosie will talk about later. Then we've got fertility issues, pregnancy, having a pregnancy in the 40s and all of those issues that go with labour, delivery, what sort of delivery, motherhood, and where does it all fit in with career, or where does motherhood or career, whatever, vice versa.
It's a tough time in a way, isn't it?
Yeah, it really is. It's a big issue.
What about early menopause? Does that happen?
Well, then we're looking at women in their 40s who've gone through an early menopause, in their early 40s. And then if we look at the perimenopausal issues, contraception, what do women do about contraception in their 40s? And then we need to look then at the pathological conditions that can happen, things like fibroids or endometriosis. And of course, we mustn't forget endometrial cancer or other cancers such as breast cancer.
So in other words, a lot of those more serious conditions tend to happen or start in the 40s? May, but not always. Rosie, from your point of view, you've been working as a sexual physician. Is that the right way to describe what you actually do?
Yes, well, it's probably better to say sex and relationship therapist.
Right.
That way everybody understands what I do.
And they interact, don't they?
Yes, that's right. And for women in their 40s, it can be a time of great change in their relationships and even in their sexual function. Now, John, from a relationship point of view, these women can be at all sorts of different phases. Some the relationships are maturing. Some the relationships are ending.
Going out the door.
Yeah, some they're just beginning because they've found a new love, which is wonderful. But then, of course, there are other women who are enjoying being single, and then there are those who are still looking for love. So tremendous variety there. And of course,
Is that greatly changed from, say, the 30s? Have you noted a major change from the third decade to the fourth?
I think that there's been an increase in divorce rates. I think that a lot of women are repartnering in their 40s, you know, for the second time. We're getting blended families. We've got women who have decided that they want to stay single and not have any children. I mean, there are great variety there. And whatever the phase in the life is, there's always challenges and there's always opportunities. Now, from the sexual point of view, a woman can start to notice a bit of slowing of sexual function in the 40s, and a particular problem, which we'll be talking about later, is some dryness during intercourse and discomfort. But also men can notice changes in their 40s too, and if a man has poor health or he's a smoker, he might start to notice problems with erections around this time.
Right.
So, I mean, if you can't find a solution for yourself for these problems, for relationship issues or sexual issues, do go and see a professional and get some advice.
And that's important. So I want to throw it back to you, Liz. You once said to me that the 40s is a fabulous time. I remember you telling me. Now, why is the 40s a fabulous time? And of course, that's what we're talking about today, the fabulous 40s.
Well, I think it's a fabulous time because women, by the time they get to their 40s, really should know who they are. And I think that they then are able to look after themselves in a much more dramatic way.
And I suppose the childbearing, to a degree, for most, has slowed down or finished.
Well, that I think in this day and age, we've still got most women in their 40s having had children, but as Rosie's just said, we've got such a blend of what's actually happening in life now, and we have many more women who have delayed their relationships and children because of their careers.
Yes. And that carries its own problems.
Yeah, and they've focused on their careers and they're having trouble finding relationships. There are a lot more men and women delaying relationships, permanent relationships for a long period of time.
Well, tell me, being more specific, I'll drill down. What's actually happening for women in their 40s in terms of their reproductive life, their fertility changes might be occurring, hormonal changes? What's actually happening there?
Well, I'll say first that optimal fertility is actually between the ages of 18 and 28.
Now, that's amazing. People don't realise that.
And the average age now for first child in this country is 29. So there are very, very, very subtle changes that occur in the late 20s. But we see...
And not so subtle changes.
Well, no. In the late 20s and early 30s, they're very, very subtle. Most women will be totally unaware of them.
Right. You mean hormonal changes?
Yes, we see very, very small changes in follicle-stimulating hormone, which is that hormone that comes from the pituitary gland that stimulates the ovary, gives it the message to produce hormones. And we see that very slowly starting to change, to elevate after 35. But then it sort of rises exponentially. Dramatically. So it's a bit like a curve that starts off slowly, and then when you get to the 40s, it just goes rapidly. In fact, it's going the other way. It's going down because what's happening is that, the number of eggs are just diminishing rapidly.
Because they've been there since that lass was born, haven't they? It's not as if they've been created.
Well, they've been there in utero.
Always.
Dramatically. And then at birth, I think we have about 1 million eggs in each ovary, and we ovulate about 500 times. Western women ovulate about 500 times in their reproductive cycle because we have so many periods and so few babies. And then, so yet we finish up at menopause around 51 with no functioning eggs.
Right.
So somewhere over that time, those 2 million eggs have diminished absolutely.
So if we get back on topic to fabulous 40s, you're dealing with a time where fertility, as you so rightly are saying, has gone down.
Yeah, so what happens is that there's an increasing change in the hormonal regularity in the 40s. So as women move into the perimenopause, that transition that leads up to the final menstrual period or the menopause.
Which is how long?
On an average, 4 to 6 years. Short as 1, long as 10. So in that period of time, we actually see very subtle increase in the follicle-stimulating hormone. And in the late perimenopause, so about the last 1 to 2 years, we see a rapid rise in the FSH levels. But what happens interestingly to estrogen is that it goes up and down and all over the place. And in fact, it can be very high.
And is that why you'll hear people say, women will say my hormones are out. There is such a difference between the estrogen and the follicle stimulating hormone.
Well, the follicle stimulating hormone is really a messenger. It's just giving us a message, but it's not telling us when and how long it will take to get to the final menstrual period. But it's giving us a message to suggest that ovarian function is winding down. So some days the estrogen will be really low, so women might, in their late perimenopause, have hot flushes and sweats and a dry vagina. But the next day they may have a very high estrogen, so they'll have sore breasts and they'll be feeling ratty and horrible and snappy and bitchy and they'll feel very premenstrual, as if they're about to have a period.
And that's why it's not worth a doctor.
It's a waste of time doing blood tests.
Blood testing for estrogen, waste of time.
Because it doesn't tell us when. It doesn't give us any information except to say, well, yes, there are changes going on.
Okay. So these hormonal changes are the reason why women in their 40s may be having the changes to their periods.
Yes, that's true. And in that transitional phase, the majority of women will tend to have, as they move closer to that final menstrual period, the menopause, they will have decreasing cycles. So they'll have less flow, less often. So they may go to 6 weekly, 3 monthly, 6 monthly, and eventually one day the periods will stop. Another group of women will just go on having a monthly period, and then one day they just don't happen again. And then the third group that are the group that really need to perhaps be checked by their doctor are those women who have heavy periods that sometimes are flooding and are really becoming a problem to them. May be associated with anemia, can be associated with period pain that they didn't have before. And also they may notice an increase in premenstrual symptoms. And that may be due just to those hormonal changes that are happening. Because the other thing that's been found recently from research done in Sydney is that we can ovulate twice in a cycle in that perimenopause. So the estrogen levels are going up and down, and so you can have one period that's absolutely flooding and another period that's very light. So these changes, but you can have the pathology of fibroids, endometriosis, adenomyosis, and even cancer.
That's what I was going to get to. Just tell me about these conditions, fibroids, etc. So fibroids are much more common in the 40s than they are in the 30s, and indeed...
Well, more than 50% of women will be found to have fibroids.
What are fibroids?
Yeah, by the age of 50. So fibroids are benign, fibromuscular tumours in the wall of the uterus. So if you could imagine a bit like the inside of a golf ball, but if you can think about little golf balls all throughout a woman's uterus, literally fibroids have an appearance like that. They have a white pearly appearance which is quite swirly when you cut the surface of a fibroid. So most of us will have fibroids by the time we get to menopause, but only a small number of women will have fibroids that will cause trouble.
What makes the fibroid cause trouble?
Well, there are a number of things. There are 3 types of fibroids. There's one that sits in the wall of the uterus, so it just enlarges the wall. There are some that bulge onto the outside of the uterus, so that alters the shape and the size. And there are others that are inside the uterine or bulge into the uterine cavity. They're called submucosal, and they will increase the surface area of the uterus.
So you might bleed more because
you're going to bleed more. But also, if the uterus is bigger, and sometimes you can have very large uteruses due to these fibroids, and we would see these very large fibroid uteruses in women who may not have had children or who have a family history of fibroids. And sometimes they're enormous.
And they're pressing on things because they're so big.
They cause pressure on the bladder, they cause pressure on the bowel, and women can feel a hard lump in their tummy.
What about the urinary tract as well? Can upset that as well?
Yeah.
So it's awfully important at this time of a woman's life that she can go along to a doctor and have a checkup. Because
if she's got symptoms like that, she should go, but she should have a checkup, but we'll talk about that later.
All right, okay. Now,
Can I talk a little bit about adenomyosis, just
yeah,
briefly?
just remind me of what it is again.
Adenomyosis means adeno, glands, meiosis, muscle. So
Right.
glands in the muscle. And it's the lining cells that we shed when we have a period growing inside the muscle. And in the 40s, we often see it in women, and it gives a thicker muscle of the uterus, so women get heavier, painful periods. They have a bigger cavity because it stretches the uterine cavity. And so they've got a larger surface area again, a bit like having the fibroids. But they can cause pain with intercourse as well. And it's just like the uterus looks much more globular. It looks like a small grapefruit or an orange or something like that, and a bit soft.
Now, the other thing you mentioned when we were talking earlier was endometriosis.
So
just remind me, once again, what is endometriosis?
Well,
the endometrium is the lining, the inside lining of the womb.
Okay, well, that's it. It's the inside lining of the womb, those cells growing in sites outside of the uterus.
Such as?
Excuse me. On the ovary. So if I'm a uterus and my hands
She doesn't look like
are
a
my tubes, so when we have a period,
Yeah.
the blood comes out the tubes as well.
I see, and that's what causes the pain.
And so, no, it doesn't cause the pain. But in women with endometriosis, when the blood falls inside the
Oh,
abdomen...
you're saying normally the blood can come out the
Yeah,
tubes?
it does with everybody.
Right.
So we have a period, but we also have blood coming out the tubes.
I wasn't aware of that.
Yeah. So if
I
you
should know that, but I wasn't aware of that.
Yeah. If you do a laparoscopy in women who are menstruating, having their period, you'll find blood in almost everybody. But what happens in those women who don't have endometriosis, that blood just gets absorbed naturally into the body by all the cells that do that. But in women with endometriosis, those cells stick onto the lining inside the abdomen. Now, it might be on the ovary, it might be on the tubes, it might be down behind the uterus, it might be on the bowel. And whatever the process is, those cells start to grow. And eventually they can form little nodules of tissue, and they shed when the period comes. So then blood's sticky, and so then the tubes and ovaries and things. So in women with severe endometriosis, you can have severe pain and symptoms, infertility, all sorts of different. Painful periods is usually the main symptom.
Okay. Now, just before, I'm going to stick one more case to you, and you mentioned endometrial cancer.
So endometrial cancer can occur mainly postmenopausally, but very occasionally it can happen in women in the 40s. Why that is so? It can happen in women who have polycystic ovary syndrome, who have estrogen secretion without ovulation. And so if the lining starts to thicken without progesterone, then the lining can get thicker and thicker, and eventually over a period of time they can develop an endometrial cancer. So it is a condition which we very occasionally find in the 40s. And of course, if it's found in the 40s, women will have to have their uterus and ovaries out, so we then get the added problem of a surgical menopause.
Now, we're meant to be talking about the fabulous 40s, but all we've done so far is talk about the nasties. Liz?
Well, yes, but we have to be aware of what can go wrong.
Right.
I think that's, and I think we have to remember that the majority of women still have a pretty fabulous life in their 40s.
Okay, so I'll buy that argument. Thank you very much, madam. Many women in their 40s, nonetheless, because their periods have become irregular, might think, oh, I don't need a contraceptive anymore. What do you say to them?
Our recommendation is that women use contraception until 12 months after their final menstrual period.
They don't, though, do they?
No, they don't. But that's our recommendation.
Well, what are the most suitable forms of contraception, especially keeping in mind some of the nasties we spoke about just a moment ago?
Well, I think the first thing is to take into consideration a woman's health. So in deciding her, we have to look at what her state of health is, whether there are any major health risks, both in her or her family history, before she decides on what is the contraceptive for her. Now, if she's a woman who has had her children, she's not intending to have any more children or even the thought of it, then permanent contraception might be the best thing, and the best permanent contraceptive is vasectomy.
Oh, yes. If there's good trust between the couples, that is.
Yes,
Yeah.
that's right.
Are you waving a little flag about that?
Well, I think it's a very important thing because
But
women...
it is interesting, isn't it?
Yes, I mean, women usually take charge of contraception. And I think contraception is a couple responsibility. And so if a woman has been the one who bears the children in those relationships where children have occurred, then I think the other partner needs to take responsibility in some way as well.
Rosie, would you agree with that?
Well, I would, and I think that many women get sick of attending to the contraceptive needs of the relationship, and they feel that it's time that he took a turn.
Yeah, okay, all right. It's a good point. It's a very good point. Let's get back to the nasties, though, because...
No, well, can we talk about the niceties in a sense that the contraception is actually allows niceties to happen. So if you've got good contraception and you know that it's a contraceptive that's working, then sex can be much more enjoyable and you can be freer in the way in which you express yourself. And so using the oral contraceptive pill up until the time of menopause in healthy women is a very good contraceptive. It's also going to regulate periods. And so it's a very good form of contraception. It's also a good treatment in the perimenopause if women are having symptoms. But if they don't like the oral contraceptive, there's the new NuvaRing, which is the ring contraceptive of estrogen and progesterone, has a very low dose.
Yes.
Then there are progestin-only pills, but I think that they're probably mainly used only in women who are breastfeeding. But then we've got the long-acting ones. Fantastic. I mean, the contraceptive rod, Implanon, lasts for 3 years. Fantastic.
And it's cheap.
And it's cheap. And the Mirena IUD, the levonorgestrel releasing IUD, it stays in for 5 years. But I shouldn't say this, but when women are in their late 40s, it actually can stay in for 7.
But
So,
not enough people know about that. And when you mention intrauterine devices, they think back to the bad old days. It's all different now.
But it's also the treatment of choice for heavy periods in the 40s, and it also is the treatment of choice for women who have adenomyosis, because that's all we've got at the moment. So, and it can be used for suppression of endometriosis. So,
And of course, you've still got condoms.
and condoms. Condoms.
Condoms. Now, which brings me to you, Rosie. On the subject of sex, let's get down to one of the issues that was most topical in the survey that the Foundation carried out. Libido, where has it gone and how do I get it to come back? It's also the topic of your new book, Rosie.
Yes, I wrote Where Did My Libido Go? Because loss of libido in women is the commonest problem that I see in my study of 2 to 59. On average, reported that they lacked libido for at least 1 month in the last year. Not alone,
They're
that's
not
for sure.
alone.
They're in good company. Now, every woman's going to have low libido at some time in her sometime in her life, because she might be short term. She might be going through a rocky phase in the relationship, or after the birth of a baby, or a particularly stressful time in her life, or it might be longer term. Now, if it's short term, it's not usually a problem, but if the problem becomes persistent and the woman's in a long-term relationship, it can cause difficulties because she's not in the mood and her partner wants sex. Now, of course, this doesn't have to be a problem. If the partner is quite happy to have a no sex or low sex relationship, these people are perfectly matched. But that's not the typical picture that I see in clinical practice. What I see in clinical practice is particularly the male partner wanting sex more often than the female partner.
What are the specific things that do lead to a loss of libido that lasts and goes on?
Well, we can talk about physical problems, all right? Poor health, for example, fatigue. Almost every woman that I see in my clinical practice with low libido says she is tired. Maybe all women are tired. I'm not sure about that. But also some medications, the SSRI medications, which are very commonly used.
Antidepressants?
Antidepressants can reduce libido. Then there are emotional issues, so stress, anxiety, depression. Depression is a real passion killer.
One in 5 Australians will get depressed at some stage in their lives.
A very, very common problem and something certainly to look out for. Then we've got sexual problems, and it might be loss of attraction to the partner. I mean, he might be walking around in tracky dacks and not shaving and not having a shower. Well,
Steady.
He doesn't turn her on anymore. Or it may be unfulfilling for her. And then there are relationship issues. My motto is you cannot have good sex in a bad relationship. Right? I think it's not in the long term, it's not possible. So a lot of women have unhappy relationships. They don't like their partners anymore, and that's why they don't want to have sex with them. And finally, a lot of women have an anti-sex lifestyle.
Now, what do you mean by an anti-sex lifestyle?
Well, it's important to look at any factors that might be turning down sexual desire and try and either reduce them or eliminate them. So, for example, if you've got poor mental or physical health, right, go and get a checkup. You might have depression, you might have diabetes, you might have low thyroid, you could have some other chronic illness. So that's really a really important start. Now, if your relationship is poor, all right, try and sort this out with your partner, but if you can't sort it out with him, then seek relationship counselling. Relationships Australia has branches all over Australia. Just go on the web and you'll find plenty of counsellors who can help you with that. Now, if sex is a problem, if you find sex unsatisfying, that's something also that you need to address with your partner to try and increase your sexual enjoyment. And if you're having problems there, then you need to seek expert advice. So go to your GP, and your GP will know a psychologist or a doctor who works in the area of sexual counselling.
But indeed, you should start with your partner.
Well, yes, first of all, talk to your partner, and then if you can't sort things out with him, then go on and seek some professional advice.
But you know, so often when you're talking to women in their 40s, they're trying to be a superwoman. They're trying to do so much, not just for their family, for their careers, for their partner, etc.
Yes, well, often these women are called, in their 40s, are called the sandwich generation, because they're squashed between their growing children, sometimes they're little, sometimes they're teenagers, and their ageing parents. And they feel the pressure from both ends. Often they've got careers, they're doing double shift at home and at work, and these women are really, really tired. And this is what I call an anti-sex lifestyle. So what I say to these women is you've got to reduce the load, right? As you say, you can't be superwomen. You know, you can't be a perfectionist. You can have it all, but you can't do it all. And I say to women, prioritise, delegate and prune. In other words, what is it really, really important? You know, the dust will still be there when the children go off to university. I can promise you that. Delegate.
Me too.
Yeah, that's right. Delegate. And that is, you know, who can help you? Ask your husband for help. You know, ask your children for help. You know, get as much help as you can.
Get a cleaning lady.
Get a cleaning lady. If you can afford it.
Save up for a cleaning lady.
Yeah, if you can afford it. And finally, so prioritise, delegate and prune. You know, get rid of anything, all right, that is not absolutely essential. And these are things that you can do initially to try and reduce the desire inhibitors and enhance sexual desire.
Now, isn't it true that if people's libido has gone flat, they look back to the early days when it was hot for trot, as you so rightly say? Why has it changed?
Well, when couples first get together, all right, and the advice that I'm going to give now applies to male-female couples as much as two women in a relationship. So when I'm talking about a partnership here, I'm talking about either a heterosexual partnership or a homosexual partnership. That's very important. And when couples first get together, they go into this very romantic infatuation period. It's called the Limerence Phase. And what happens is that the brain chemicals gear up and they excite sexual desire. So when women first fall in love, for the first 6, 12 months, up to about 3 years maximum, their desire is maximally enhanced. So yes, as you say, you know, they're hot to trot, the sex is fantastic, they can't keep their hands off each other, but unfortunately this is a time-limited period. And what happens is
it stands to reason though, doesn't it? Because at that stage of their life, they're probably thinking a child in the future, and this enhances them to have a baby, perhaps.
Well, that's right. I mean, although we live in the year 2010, we still have caveman and cavewoman sexuality, and our sexuality is all about reproduction. So the idea is, look, by the time a woman's been in a sexual relationship, by 1 year, 90% are pregnant. So that we have this high desire often for 1 year. If we're lucky, it might last for 18 months or 2 years. You know, if they're married to someone else, it could last a lot longer. That always makes it much more exciting. Or they live in another country. But what happens then? But what happens then is that sexual desire plummets often for women, not for all women, but for many women. And from that time on, many women will never again feel sustained, spontaneous sexual desire. Right? And this can be very, very distressing for them because they think that there's something abnormal and they should be like they were in the beginning.
What about testosterone for such a person?
Oh, right. Well, a lot of women ask me about testosterone, and there are concerns still about testosterone replacement therapy in women. There's worries about cardiovascular health and about breast health. There are no TGA-approved testosterone products for women. So it's an area in which there are no conclusive answers. And what I would say is, although some studies have shown some benefit in premenopausal women with testosterone replacement therapy and libido, it's not a dramatic improvement, number one. And number two, it's not for every woman, because after all, a jab of testosterone is not going to fix a soured relationship, and it's not going to improve lousy sexual technique, which is often what the problem is.
Okay. I suppose the other thing that happens is that, as you so rightly say, earlier in your life, you can't keep your hands off one another. But what's the situation later in life when you're both being busy, you and your partner are both being busy? Is there a message to give regarding that?
Well, one of the differences between men and women is that testosterone is the desire hormone. I've mentioned that, but men have 10 to 20 times more testosterone than women do. And what that means is he is likely to want sex more often than she is. And this can set up a very nasty toxic cycle in the relationship that causes a lot of unhappiness. Now, women with low libido can be divided into two groups. The first group are women with low libido who do not enjoy sex with their partners and who have a poor relationship. Now, for those women, the answer is to go and seek professional counselling. So a poor relationship and not enjoying sex. But there's a second group of women, and I want to talk about these because this is quite a common scenario. And these are women who have low desire, but they find that once they get going, they're fine. They enjoy it. You know, they get turned on, they become aroused, they lubricate, and they have an orgasm. And afterwards they think, why don't we do that more often? That was really quite nice.
But they don't.
But they don't, because they don't have the drive, they don't have the motivation. And what I say to these women is that they really can't afford to wait to feel lust, all right, before they have sex. Why? Because in the meantime, their relationship may suffer, and it may even fall apart, all right, because, you know, this puts a lot of strain on the relationship when one partner has sexual needs and they're not being met. Now, what I say to these women, instead of waiting to have desire-driven sex, right, they should have what I call decision-driven sex, and that's a considered, conscious decision to engage in sex for good reasons, not just for the partner, but because the woman enjoys the affection and the intimacy of it, because it's pleasurable for her. It's also good for the relationship. It also pleases her partner. But she's not just doing this as a sacrifice for him. This is not mercy sex, all right? Because this is consensual, willing sex. And not only does the woman get to decide, and when having decision-driven sex, to decide when sex happens, she also gets to decide what happens, how much she's prepared to participate. So what I say to women is, look, if you're not in the mood for intercourse, if you don't want to get aroused and you don't want intercourse with all the bells and whistles, all right, why not offer him some manual stimulation or oral stimulation? He can rub up against you till orgasm occurs. That's called frottage. Or maybe you can have a quickie where you don't really put much effort into the sexual interaction. Now, these are all low participatory sexual activities. And, you know, I often say to women, you know, when a man's hungry, he doesn't always need a 5-course meal. Sometimes a sandwich or a slice of pizza will do. And with this decision-driven sex, low participation sex, look, it may not be the kind of sex you see in pornos.
Yes.
Right? It may not be what you see in the movies. It may not be what you're dreaming of, but it's better than no sex at all in the relationship, and it's better than the tension that occurs when there's desire discrepancy.
And there's a discussion also, isn't there, that if the partner, if indeed it's a male partner, looks after a woman around the home, around the house, that things will be better when he and she get in the cot.
Absolutely. I'm so glad you brought this up, John, because the man has a very important role to play. Now, we've talked about the woman making compromises. The role of the man is to create as much goodwill in the relationship as possible, to attend to her needs, her emotional needs, her physical needs, her intellectual needs, her spiritual needs, her domestic needs. You know, often I say to men, you know, if you really want to turn your wife on, get into rubber, rubber gloves, all right, and do the washing up. But support around the house, you know, help with the kids, because this makes a woman feel equal. It makes her feel valued.
Yes.
It makes her feel supported. And if she has goodwill, then she is far more likely to be sexually generous
Yes.
to her partner.
Absolutely.
And this negotiation that I've talked about is based on goodwill and sexual negotiation and compromise. And that actually strengthens the relationship.
Which is ideal. Can I ask you this question, Liz? Going back to the earlier part of our discussions, we were talking about difficulties, gynecological difficulties. For example, the vagina might be dry, intercourse might be painful. People often come to you to talk about these things. Tell me about it.
I think that women in their 40s who come with painful intercourse will come with a number of issues. Sometimes they might be related to birth issues. So if they've had a baby in their early 40s or late 30s, they may have some problems with their vaginal entrance because of having had stitches there. And sometimes that can become a bit tight or a bit dry. They may have some of the conditions that we've just talked about, that adenomyosis goes with painful intercourse. And I think pain with intercourse, no matter what it is, whether it's dryness, tightness, or whatever, is one of the most important factors that will turn a woman's libido off.
I'm sure that's right. You would agree, Rosie?
Absolutely. If a woman has discomfort with intercourse, that's called dyspareunia, she should first of all go to see her GP and get a checkup, because there are many different causes, as Liz was saying, for uncomfortable intercourse, and they have different treatments. But something that women might notice as they get into the 40s and the late 40s is vaginal dryness and fragility and reduced lubrication. Now, this is due to reducing levels of estrogen in the blood, and it's called atrophic vaginitis. Now, atrophic vaginitis is a really common cause of dry, uncomfortable intercourse. Now, there are a number of different options. Now, for some women, a lubricant is enough, something like KY jelly or silk, that's enough. Other women, particularly if they have other menopausal symptoms like hot flushes, may find that hormone replacement therapy, so pills, patches, that kind of thing, is going to be the most beneficial for them. But interestingly enough, about 30% of women who take systemic hormone replacement therapy still have atrophic vaginitis. So they may need another option, and that is local applications of estrogen to the vagina. Now, this can be pessaries or cream. The pessaries are called Vagifem pessaries or Ovestin pessaries or Ovestin cream.
All on prescription?
Yes, these are on prescription from the doctor. And these are inserted into the vagina every night for 2 weeks, all right, that's the baseline, and then a couple of times a week. Now, this is a lifetime treatment, because the moment you stop, the problem comes back. But I kind of like the idea of applying estrogen to the vagina, because it means you can be 90 and you can still have a 19-year-old vagina. I think that sounds fantastic.
Wow. There's one other factor, if I could just butt in, is that we haven't talked about the fact that women could have a vaginal infection. So chronic thrush and vulval, say an allergic vulval reaction to perhaps dermatitis, those sorts of things.
Psoriasis,
yeah,
lichen sclerosis.
Yes, all of those conditions can cause irritation and so discomfort with intercourse. And if women haven't had those treated properly,
and they can all be treated properly.
yes, they can.
Yeah.
They can. Yes.
What about replens?
Oh yes. Now, and I think this is something that Liz mentioned to me, and that is, you know, when you might like to answer it, what about women who've had breast cancer? Can they have hormonal treatment?
So women who've had breast cancer and perhaps those women who have had chemotherapy premenopausally and in their 40s, and they then develop a chemical menopause from the chemotherapy. With vaginal dryness, it really depends on the doctors that they are seeing for their breast cancer, but there is good evidence to suggest that the use of the estriol or Ovestin cream twice a week, long term, has no adverse effect on cancer.
That's important, isn't it?
Because
mention the word estrogen and women with breast cancer get very, very frightened.
Now the Replens, and now if women can't have estrogen, Replens is another good option. This is a moisturiser that you buy over the counter at the chemist. It's also applied 2 to 3 times a week. And it actually has, it's not just a moisturiser, it actually improves the structure of the lining of the vagina. So Replens is another option for women who have dry, uncomfortable vaginas.
Now, I suppose one of the things we haven't talked a lot about is the emotional well-being of a woman.
Yep.
We mentioned that 1 in 5 people, Australians, men and women, get depressed in their lifetime.
Yep.
Depression often associated with anxiety.
Yep.
And there are other problems as well. How do you both cope with that when you're talking to women in their 40s?
Well, certainly hormonal changes can cause problems such as mood swings, irritability and anxiety. But we're really beginning to understand more and more that it's not just menopause that's creating these problems.
Or perimenopause.
Or perimenopause that's creating these problems. And there are a lot of other factors often operating in a woman's life, factors such as her personality, her previous mood problems. So a lot of women have a past history of depression. Her attitude towards ageing and towards approaching menopause. Some women celebrate ageing. Other women just absolutely fear it and feel very uncomfortable. Her relationship with her partner can make a difference. Her current stresses, what's going on in her life. Lifestyle, having a poor diet, too little exercise, not looking after herself. And physical symptoms of perimenopause can also affect mood. So hot flushes and night sweats and sleep disturbance. So all of things can make a difference.
Yeah, you've talked about the idea that many women try to be superwoman in their 40s because they're trying to balance all of those different aspects.
Yes.
And I think that in many women that just becomes too much. And so the stresses of all of that are immense.
Isn't it true that at some stage with perimenopause, that, and indeed with menopause, that a low dose of an antidepressant can be of benefit?
Well, yes, there's a number of things that you can do. I mean, for a lot of women, because there are these wild swings in estrogen, there can often be wild swings in mood, and women can feel like they're on a bit of an emotional roller coaster. Now, hormone replacement therapy with estrogen has a tranquilizing effect on the brain. And in some women with mild depression or mild anxiety, it can help. But women have to watch out for depression at this time, as they do at any other time. Now, menopause and perimenopause doesn't cause depression, but women who've had depression in the past
Becomes a trigger.
Yeah, it can be a trigger, or it's more likely. So the typical symptoms of depression that women need to look out for example, problems with sleeping, problems with appetite, problems with energy, difficulty concentrating, loss of pleasure, loss of libido, all of those sorts of things. And what women can do if they have emotional difficulties is they can share their feelings with their partner, with their friends, they can talk to a counsellor. A lot of women say that they really benefit from a self-help group, particularly, of women in the same situation. So find a self-help group, or better still, create one for yourself and your friends. Exercise can be very good for mood. 30 minutes of vigorous exercise creates endorphin release, the body's chemicals like morphine or heroin, and that improves mood for 12 hours. Relaxation, yoga and meditation. These are all things that women can do.
Now, Rosie, if the mood swings are still there, if anxiety comes along, if depression is about, what should a person do in such a case?
Look, the most important thing is to go and have a checkup, because depression is a life-threatening illness, right? And you must exclude that first. And the treatment for depression is usually quite straightforward. Often it's antidepressant medication, plus or minus counselling. Another thing, if the doctor rules out depression, a lot of women are interested in more natural therapies. So going to see an accredited naturopath might be another option for them.
And I think the point is important. Accredited naturopath. Be careful who you go to. I know
Absolutely.
Jean Hales is a fantastic naturopath that I often use on my radio show. It's
Oh,
really,
right.
really good. Just finish up by talking about...
Can I butt in?
Yes, please do.
I think that women in their 40s, when they've got mood issues, as part of their whole lifestyle, I think they should do the 3 things that you recommended before.
Oh, prioritise, delegate and prune.
I think that is a message for women of all ages.
Yeah.
Prioritise,
absolutely. Delegate
delegate
and prune.
and prune.
That's the
right.
hardest thing in life to do, is to
3
prune.
important words.
Yes.
Liz, while we're talking with you, One of the problems about people who feel emotional is that it goes through the day into the evening and indeed disrupts sleep. And sleep disruption in the 40s can be a real issue.
Well, I think we have to exclude what the cause is, and that's very important. As we've mentioned, depression is a very common cause of sleep disturbance. We have to see if there are emotional reasons for that, but it might be that women are actually into the perimenopause.
Yes.
And we are talking about all across the spectrum of the 40s, but when we talk about the perimenopause, we're really talking more about the second half in most women. And wakefulness is not an uncommon symptom of women in the perimenopause.
Even over and beyond, say, hot flushes in the
it's
evening.
got nothing to do with having hot flushes or sweats. There's this sense of wakefulness. You just wake up in the middle of the night
Can't go back
and
to
you
sleep.
think, God, I've got enough energy now to go and clean the house, write a paper, do whatever. And there doesn't seem to be any reason. If they're women who are developing perimenopausal symptoms of flushing and sweating, then that will be another cause of waking up. But we have to think about other health reasons that might actually also be influencing, such as sleep apnea.
Yes.
Those sorts of things.
And
So it
that's
depends
the
on-
reality in women. People don't appreciate it. And I suppose...
Well, a lot of people don't know what sleep apnea is.
Yeah, that's right. Stopping breathing while you're sleeping, due to the changes that are happening in the fat in your body, etc. More common after the menopause, but still exists.
It still exists, and it may depend on weight and health reasons and all that
Absolutely.
sort of things.
I suppose, too, getting back to your three words of a moment ago, too, a busy woman will often keep herself going by having coffee in the afternoon and things like that, and that
Absolutely.
alone.
A glass of wine while you're cooking the tea.
Or two.
Or
all
three.
that's
Can that interfere with sleep?
Yes.
Yeah.
absolutely.
Alcohol is terrible.
A lot of people think that having a drink helps you sleep.
But it can do the opposite. in fact.
Gets you to sleep, then you wake up, don't you?
Yeah.
Not that I would know, of course.
Oh, no,
Yeah.
not at all.
But look, that other point, Liz, that I remember you telling me, to go to bed at the same time and get out of bed at the same time every day, that routine.
Well, a routine is very important, and most of us don't have a routine. But if we do have a routine, and when we wake up, get up, and if we wake up at night and our minds are going around like that...
Get out of bed.
Yes, but not only get out of bed, because you're usually trying to solve the problems of the day that have just happened, or you're trying to prepare yourself for the problems of the next day. Get out and write a journal.
Yes.
Put it down, get it out of your mind.
Close the book.
Close the book and then go back to bed, because when you wake up in the morning, you'll have it all written
all
down
there.
and you won't have forgotten.
Do you know, research has found that people who keep journals are far less likely to get depressed and,
Yes.
have,
Exactly.
and have better mental health.
Exactly.
So journal keeping is actually
Yes.
a wonderful thing.
And when you wake up in the middle of the night, don't look at the clock.
Yes.
Yes. Don't have one of those digital lit up ones where you can see it in the darkness.
I know.
I know, I
Every
did
Can't
that.
get away
I
from
did
it.
that the other night.
It even scares the cat.
the cat coming in, yes. Lock the cat out.
And I suppose the other thing, Rosie, is you should use your bed for sleeping and sex and not for anything else.
Absolutely. That's
And
my
don't-
rule of thumb.
Don't have the television in the room.
Oh, absolutely. A television is the greatest passion killer in the history in the bedroom.
I'll just watch
It's
the end of the film.
Yes, that's right.
And
That's
so
right.
magazines are there to stimulate you.
Yeah.
So, you're trying to go to bed and you're reading one of those weekly magazines that people write for, like
Yeah.
yourself and myself.
I have to tell you, though, that I go to sleep doing a Sudoku.
You must be tired.
Now, we started off by sort of saying that the 40s are is a period of time where a woman can look back on the past, look towards the second half of her life. It's a time of reflection. But prevention now really starts to play a big role, doesn't it? Prevention in chronic diseases which may follow the 40s. Where do we start?
Well, the first thing is to talk to your doctor, because the kind of medical checks and screening procedures that you need will vary according to your individual health risks, your past history, your family history, that kind of thing. But some possibilities, all right. Bone health review, a bone density scan, especially for those who have early menopause, because we're worrying here, of course, about osteoporosis. That's weakening of the bones, and that can be a real problem as women get older.
One in two women over the age of 60 have osteoporosis.
Yep.
which is incredible.
Yeah.
And very often when they come to the hospital with a fracture, minimal fracture,
It's the first time.
It's the first time, and they're not picked up at that stage of having osteoporosis. It's a real worry.
Yeah, yeah.
I suppose the other thing that concerns me is women think they're going to die of breast cancer.
Well, we know from the studies that the majority of women think they're going to die of breast cancer, and 4% of women will. And they think that about that amount, 4% will die from heart disease, and in fact more than 50% of us will die of heart disease.
Yes.
So there's a misperception about health. So we worry about having mammograms and getting breast cancer, but we don't worry about our blood vessels and our cholesterol and our blood pressure and our weight.
Well, you're worrying about your partner who might be 5 years older than you, but you're not thinking the same thing's happening to you.
The problem, of course, is as we age, we're less likely to be investigated for heart disease as you men are. So if we have a bit of chest pain, we'll be told, oh, it's stress or anxiety, or perhaps it could be reflux, whereas it might be heart disease. But it's the 40s where women can actually start to, it's a bit like an insurance policy. You take it out when you're young and you work on it and you keep building it up until, and so you're going to then recoup it when you've retired or whatever. It's like your super. So the 40s is now the time in which we can try and avoid putting on that weight that
I was going to ask you specifically about that.
Most of us do.
That tummy weight, the change that happens 40s and 50s.
We become more like men.
Yes, we do. We do. Well, we lose our hourglass shape.
Yes.
It's very depressing.
Someone was telling me that women who actually go through the menopause don't move as much as they used to.
But that's an ageing process across both sexes.
Yes.
So that's part of the reason why we put on weight is that, we put on weight, we start to change our body shape in our 40s because of our changing hormonal milieu and also this slowing down of metabolism. And we also don't exercise as much. And so consequently, we get this android shape. So we get more fat around our bellies. And that's where our waists expand.
And that's the dangerous fat, of course.
Yes,
that's right. The fat that's actually inside the body that puts out these nasty cytokines that cause a lot of trouble. So 80 centimetres is if you're below 80, that's all right. If you're Asian, it's even less, isn't it?
Right.
Yes. So it is culturally, we're talking mainly about Caucasian women, but there are always standards for women across other cultures as well.
And the other thing is getting once again back to your constant women trying to be everything to everybody and everything to their families, etc. Exercise goes out the door as well.
There's one little point here, if I could just read it from a research that we've done at the Jean Hales in women between 25 and 50 with young children. An intervention that focused on behavioural change, such as setting goals, developing a plan of action, monitoring weight, walking and simple changes to food intake was able to prevent weight gain.
That's
and if you can prevent the weight gain...
Much easier to prevent it.
Than to lose it.
Than to lose it, because most people lose it and then they just put it back on.
Gets back to the 40s again. You can plot and plan that as you progress through the 40s.
Yeah, and if you keep your waist circumference below 80 or below, you reduce your risk for these chronic cardiovascular illnesses as we get them as we age.
And we doctors, we general practitioners, are being encouraged to do regular testing, and it should be well and truly underway by 40. What are the things that you both think are important to test?
Well, obviously, a pap smear is very important.
Many don't have it.
No, many don't have it still, and that should occur every couple of years.
And many, pardon me, butting in again.
Yeah.
Many stop when they get to the menopause.
They don't think they need it anymore.
No.
But you need it till you're 70. That's right, Liz.
Well, the age that the NH and MRC have is 70, and women can still have a pap smear afterwards. And I think if women are still on medication like hormone therapy, they should still be having regular checks so they can even have it when they're late. But in the 40s, women should be having them every 2 years.
Yes, and when they do a pap smear, they also check, they feel your uterus and they feel your tubes and ovaries and just make sure that everything within the pelvis, not just the pap smear, and usually they'll do a breast check at the same time.
And it gives you the opportunity to say, well, look, I am having trouble when I go to the loo, or I'm going too often, or I'm constipated or whatever.
And some some community health centres will have their nurse practitioners.
Yes.
And in rural and remote areas, they'll have women's health nurses, and they will do women's health checks. They'll do their pap smears. So it's not as if they even have to go to their GPs.
Now that's interesting, because I know the Flying Doctor is flying women locums in right around the inner part of Australia to assist the doctor who might be male.
Yeah, but we went to Longreach last year, and we met all these women's health nurses who are doing regular health checks on women.
Fantastic. One of the things I want to go back to something you said earlier, Rosie. Second-time relationships can happen in the 40s.
Yes.
So sexually transmissible diseases or transmitted diseases shouldn't flow from your brain, should it? It should be reconsidered.
No, and also condom use. And a lot of these women have never used a condom, and their partners have never used a condom in the past. You know, the sort of what I call the women and men who are recycling. and they feel uncomfortable about it, and they don't like to negotiate safe sex. So it's terribly important that you have a sexually transmitted infection test before you set up with a new partner, before you have unsafe sex. But condoms, you know, that's terribly, terribly important. And that keeps you safe, it keeps your partner safe as well.
The other thing I wanted to mention, absolutely, is colon cancer or bowel cancer. You know, 1 in 20 of us will die of it, and yet if you get it early,
it's curable.
It's curable. Yeah. And it's interesting, more and more cases are now being picked up in the 40s.
Yes. So if there's a family history of bowel cancer, it's very important that women ask their GPs to either do that, they can do the fecal occult blood test, or whether or not they should have a colonoscopy.
Yes, absolutely.
And speaking of cancer, there's also breast cancer. Of course, women should be examining their own breasts.
Yes.
And if you have a family history of breast cancer, during your 40s you should have a mammogram.
Absolutely.
And you can have a free mammogram over 40 with breast screen, an Australia-wide program. So it's there.
And it's interesting this program is going right around Australia. For some people who live in the bush, it may not be as available as they would like, but they
do have mobile units that come to most of the major centres around Australia.
Yeah, very important. Now look, I was going to say there's an official 45 to 49-year-old health check.
Can I interrupt before that and just say we haven't talked about exercise and the recommendations on exercise, and those are that women actually should do about 30 minutes every day.
I know.
That's pretty hard to keep that.
It
you know,
is.
it's important to look at one's diet and have a balanced diet, proteins, you know, carbohydrates and low fat.
Now, what about the 45 to 49-year-old health check? It's a Medicare health check which you can have once. The importance of that?
Well, before we talk about that, John, I'd just like to go through the screening we talked about that should occur in the 40s. We've talked about bone health, we've talked about a pap test, we've talked about sexually transmitted infections. We've sort of passed over blood pressure, glucose and cholesterol. We talked about heart disease, plus your body mass index and waist circumference that should be measured regularly. I mentioned a mammogram, but something we haven't mentioned is a blood test for your iron levels. Right, this may be required depending on your dietary intake and your menstrual cycle. Women who are losing a lot of blood, you know, having heavy periods during the perimenopause are more likely to be iron deficient. And then we mentioned colorectal cancer.
Yes.
So that's the lot.
And Liz, obviously that will be picked up in the 45 to 49-year-old health check.
Well, that's a general practice health check, so you're probably better discussing that.
Well, this is a health check that's part of the Australian Better Health Initiative, and its aims, and I've got them here, to assist with the prevention of chronic disease, to enable early intervention strategies to be put in place, and a health check at this stage of life can assist patients to make necessary lifestyle changes or delay the onset of chronic disease. So talk to your GP and see if this health check is for you. Now, it's only for patients aged from 45 to 49 years inclusive, so if you're 45 or 49 you still qualify, who are at risk of developing chronic disease. Now that decision is made by the GP, but if you've got risk factors, and the risk factors, if you're a smoker, you don't have a lot of physical activity, poor nutrition, alcohol misuse, high cholesterol, high blood pressure, impaired glucose metabolism such as pre-diabetes, excess weight, or a family history of chronic disease, then you would qualify for this Better Health Initiative.
I think one of the important things is to know your family history.
Yes.
Yeah.
It's often forgotten.
So many women don't know their family history.
And the other thing I think is important about this test is that Oxford Health Alliance in Oxford in England has made the distinct point that 80% of the factors which knock us off the perch early are preventable. I mean, it might be as simple as stopping smoking, it might be having a mammogram or whatever, but you can make a change. Look, I think this is absolutely fantastic. It's been really delightful talking with you ladies.
Well, I think, John, the 40s are important because it's a time when
I remember
you
them.
can, when you take stock of your life and you try and decide how you're going to manage the decades ahead. And it's a time when you learn about your health and you really start to take care of your general health and your well-being. You start to look after yourself.
I think it's a time for women to really focus on their needs. I've often talked about the post-menopause being the time in which you have to be really selfish about yourself. But I think in the 40s, where you're still managing all these different things, you're the sandwich generation, that you need to start focusing women need to start focusing on themselves and really put this insurance policy into place.
Yeah, I agree with that. Do you know, the thing that I would say is that it's sad for us in general practice to open the door to the waiting room and find there's women there, and the women are thinking about the stuff that we've been talking about today. The blokes don't come, and it's a great pity that in this period of time where women are really reassessing themselves and looking to the future, that the blokes aren't doing the same thing. We might have to have a webcast on that at some stage, rather.
I think women need to learn to mother themselves.
Yes.
And do what they do for their families and those people around them. And so it's a time that you actually start to put that into your head and think about what you want for yourself in the next 40 or 50 years.
And isn't that right? 40 or 50 years.
Yes.
Yeah.
Gee, it's been good to talk with both of you. Thank you very much, Liz.
Thank you,
Thank
John.
you, Rosie.
Thanks, John.
What a pleasure.
Thank you.
Thank you so much for joining us tonight. It's been really fantastic having Rosie and Liz share their knowledge and their experience with us. Liz will be available online for 30 minutes after the webcast to answer your questions. But she's not able to give you medical advice for your own specific health problem, but she can answer questions of a more general nature. So, from the Jean Hales Foundation for Women's Health, we say thank you for being part of our 2010 webcast, and we look forward to seeing you next time.